All right, hi, this is Ashley Grill. I'm the research hygienist, and today I'm here with Dr. Randy Grill, who also happens to be my dad, and we're going to talk about the levels of care in nursing home dentistry.
Thank you, Ashley. One of the things I've shied away from in my last 11 years of going to institutions to practice dentistry is opinion-based dentistry. The ADA has stepped up to the plate and created a ebd.ada.org, which is evidence-based dentistry, which has been very helpful. But I'm going to start off on the levels of care from an article from Special Care Dentistry. And one of the incredible things about Special Care Dentistry, the same editor has been there since 1980, and all the articles apply our foundation for the next article. So even though this article on levels of care is from 2000, it's current, and it applies to my opinion of how I've practiced dentistry in the past. And so I'm quoting and starting off from an article on evaluation of an oral health education program. It is Special Care Dentistry, Volume 20, Number 3, 2000, and the head writer is a DDS, Rita Isaacson. And they call the four levels of care that I'm familiar with. One, the highest level is comprehensive dentistry. That's what you have to have a dental office for, all the dental equipment, and the epitome of comprehensive dentistry would be an extreme makeover and have that person keep that makeover for a lifetime. So comprehensive dentistry, as they define it, is to improve your oral health. The next level down is limited care, or to maintain what you have. That's usually what starts in an institution, because to do comprehensive dentistry, you need an office, you need to have it staffed. For the special needs people I have that are functionally dependent, medically complex, and oftentimes frail on a huge number of medications, which makes comprehensive dentistry dangerous, this program that I'm involved with, actually, the kids pay the bill by the insurance, then the house reduces that same amount from what the kids pay from mom or dad's money or from their Medicaid or Social Security or whatever, and then the government comes in and 70% is paid by the feds and 30% by the state of Oklahoma, and every state's different. And so if they're on Medicaid and Medicare, this is a totally paid program. Well, guess what? The program is designed by those much smarter than me to do what's safe in a mobile setting, but also there are no gifts from the government. There are strings. They didn't want to put in a clinic and have me certified in sleep sedation and have the facility judged every year and the expense that goes with that. They want limited dental care, and the next level down from limited care is palliative care, which is just, yes, there's large amounts of decay, but there's no active infection, there's no pain, there's no unexplained fever, and then the last level would be emergency care. In private practice from the Air Force from 1975 to 99, my level of practice was basically comprehensive, but people get to choose where they want to be. Those that wanted limited care or palliative care, basically, they may come in and say, do a filling, they choose it themselves, and emergency care. So private practice is based on emergency care and comprehensive care, and very little palliative and limited. In fact, one of the things in this article says it is critical for the dental professional to learn the art of good palliative care without guilt, because reparative and curative treatment may be impossible to perform in medically and cognitively compromised patients. And that's what most of my patients are. So not only will the federal government not pay for comprehensive dentistry because they won't set up a denture clinic in every place, we get to do limited care. And we will be going in different videos on minimal invasive dentistry and art, and geriatric art, which are different ways of preserving the dentition for a long time that you would never consider in private practice. Those people have no home in dentistry, but in institutions where they can say no. And my biggest problem is, like in my MR population, they have been taught they have the right to drink as much pop as they want. Pop has a pH of 2, it's got sugar, most of them don't like the diet stuff, and so I have a real trauma event in private practice. A person chooses one of the 4 levels. Well, the government has chosen the last 3 levels, limited, palliative, and emergency, for me to practice with, because that's what's safe in a mobile setting with lots of rules. I follow the AAOM, American Academy of Oral Medicine protocol or guidelines, and special care dentistry guidelines, and the EBD ADA.org on care. So 4 levels of dentistry, it's defined. That's why all my under 21 MR patients who in Oklahoma can have comprehensive care under Medicaid should not be in my program. My program starts to shine on those that have no care. Everybody must be Medicaid and Medicare. Very few people with money pay to have this done. The kids either do without, or they take them back to the dental office, which is the best. So, Dr. Randy Grill, Nursing Home Dentistry, and we will talk more about mid, geriatric art, levels of care in future videos. Thank you very much. Can you turn it off? Can you edit that out?